Welcome everyone to 2025 and the third episode of MedEd Matters, Insights and Innovations. We are so happy for all of you who are watching on YouTube or who are listening on Spotify or Apple. I'm grateful to be back for another series of episodes this year. We have a really cool series of episodes coming up on how to be an effective preceptor and what it means to be precepted. And so I have some amazing guests with me today. This is going to be a two-part series. So our first part is going to be focusing on the role of the preceptor, and our second part is going to be focusing on what it means to be precepted. And so it's going to be really awesome for those of you tuning in. So we are so excited. I'm going to have my guests introduce themselves, and then we'll get started.
I guess I'm up first. So my name's Noor Dasuki Abalanadi. Everyone, of course, just calls me Noor. I hope no one actually tries my last name. I am one of the minimally invasive GYN surgery faculty at UNC, but I'm also the clerkship director. And so I have a lot of experience as not just being a preceptor, but trying to onboard preceptors.
Thanks for being here, Noor. Dr. Kraus?
Yeah, hi everyone. I'm Alex Kraus. I am one of the faculty members in maternal fetal medicine here at UNC as well. And I work very closely with Noor as the associate clerkship director. Happy to be here. Excited to talk with everyone.
Awesome. Kayla?
Hi, I'm Kayla Stevens. I am the clerkship coordinator at UNC, and I work very closely with Dr. Noor and Dr. Kraus.
Awesome. And Bren?
Hello, everyone. My name is Bryn, and I am somebody who's a fourth year medical student at UNC. So I have lots of experience working with different types of preceptors. And as somebody who's applying into OB/GYN and really interested in medical education, I'm super excited to be having this conversation today.
This is awesome. I love all you being here, having this wonderful conversation today. And so I guess to start this conversation, I'm just curious, and our listeners really want to know, why did you go into medical education, or what brought you to medical education? I'll start with Noor.
Yeah, I think when most people answer this question, they think back to a really positive experience they had. But I'm going to twist this up and tell you actually that the impetus for me was a really negative experience that I had as a medical student. It also happened to be on my OB/GYN rotation, which probably is very surprising because you would think, wow, if you have such a negative experience, like how did you also end up being an OB/GYN? Um, but I will never forget an interaction that I had with a resident preceptor who I had been assigned clinic with, and really just beyond just like a lack of motivation, I think just due to environment and other factors, could not engage me or keep me involved as a part of the team member. And I remember entering residency and thinking, like, I am never going to be like that type of preceptor. And I kept it with me a little bit for a residency, but then got burnt out on my own and luckily made it here for fellowship at UNC. And I think entered an environment that was just so positive that it was easy to reignite that passion. And some of my greatest mentors were medical educators. So, yeah, I think that was a really pivotal moment in terms of who I wanted my professional identity to become.
That's really interesting because the same thing happened to me as a resident where I had negative influences on me from medical education. I just so happen to be doing this now. So I totally hear you. What about you, Alex?
Yeah, I will talk a little bit about the flip side, I guess, or sort of a positive experience. I think my passion for medical education actually really took shape during my time as a resident, and particularly my third year of residency, where I vividly recall teaching my intern how to perform her first 20 or so C-sections, and it was really just the two of us scrubbed in together. And I think, this experience really underscored some of the impact that you can have, with experiential learning, near peer teaching, and, how thoughtful guidance can really foster positive growth, during residency. And then I think I was also really inspired by, a lot of my additional mentors, during training that really sort of fueled my commitment to supporting the growth, and development of others in, a similarly meaningful way.
Oh, that's awesome. That's awesome. Kayla?
Yeah, I think my main drive of really getting into medical education is really just trying to give students the best experience possible and trying to alleviate any extra stressors and things like that. And so I think in my role, it's really cool to be able to kind of have a role in de-stressing their lives as best as possible. And so that's kind of what drives me in order to give the students the best experience possible.
That's awesome. So, we all come to medical education by different avenues. And I think what unites us is that we have a common thread to make sure that those that we're teaching or training are going to be in a better mindset and a better standing than perhaps when we started. And that's actually what makes medical education super awesome and beautiful. Um, we have multiple avenues in med ed. So there's like graduate medical education, so like resident and fellowship. There's, teaching faculty. There's also teaching medical students, or what we call undergraduate medical education, or UME. Um, Nor Alex, Kayla, you all are in that space. So Alex, why did you choose to specialize in UME?
Yeah, I think UME is really foundational. It's where students really develop their initial attitudes, knowledge and skills that really shape their professional identity. I think it's, a phase of, their training where we have a unique opportunity to inspire curiosity, critical thinking, and sort of compassion early on in their careers. And I think specifically, with our work within the OBGYN clerkship space, we really work to sort of bridge that gap of some of the theoretical knowledge that they, develop and learn in their first few years of medical school, into practical, patient-centered realities within the clinical practice, which I think is really, really fun.
Nor?
I initially got into UME not intentionally, and it was through the wise words of AMC, Anna Marie Connolly, for those of you who know her. And for those of you who don't know her, please get to know her. She told me that at the beginning of my med ed journey that I should really try UMEC. And she was right, because not only does UMEC have more funding, which I think can make it easier to be a leader within this level of learning, it actually has a lot of structure. And so there's a lot of room for innovation, for development. It's a lot easier when you like first want to get your hands wet into medical education because there's just more direction. You know what your objectives are. I think, when you start getting into GME, not that things are like more loosey-goosey, but it's a slow burn in terms of the way that they're learning versus I think when we look at medical student education, there are a lot of touch points and timeframes in which they have to reach a certain set of objectives. I also think it's really great to be able to bring along with you the next generation of potentially your colleagues. So, like the individuals who you get to teach as your students, residents, fellows, and then literally coworkers. And I think that's also a really fun part of being part of undergraduate medical education is when I'm at a conference and some random person I thought was random sits next to me and says, "Oh my gosh, I worked with you for 2 shifts as a medical student when you were a resident, and you were the reason I did OBGYN." And I'm like, "Oh my gosh, your name is all over the presentation or like the program for this conference. I'm so proud of you." That's really heartwarming.
We're proud, but that means we're really old. Kayla, why are you in UME?
I think to kind of echo Dr. Noor and Dr. Kraus, it's just having that small impact that you can have on a student and being able to help guide them throughout their time through their medical education. And if they end up in OBGYN or not, it's still so fun to have that small impact and kind of help them along their journey and be able to be like, that's awesome. And just kind of be able to cheer them on. That's what I really love about being in UME is just having that small impact on students' lives.
That's great. So I wanted to touch on something that you said, Alex, earlier about giving students those critical thinking skills. because I think that's something, and I don't know if maybe Bren, you can comment on this, is a little bit lacking in undergraduate medical education. Like people come to medical school, they want to know like the pathophys, the pharmacology, how to suture, all the fun things. But I don't know if we're necessarily teaching students or residents how to think. Um, what's your thought process on that?
Yeah, I think that's something that is definitely a challenge, within the realm of both, like you mentioned, UME and GME. But I think a lot of it comes from, which what we're going to touch on later on is, what is the idea of a good preceptor? And part of that is this idea of lifelong learning, self-reflection, seeking out feedback and things like that. And in the setting of thinking critically and sort of applying those theoretical frameworks that are learned within the first couple of years of medical school in the clinical context. And so I think it's really some of that is through mentorship and through just being a good role model and really helping foster a learning environment where students feel comfortable encountering challenges and asking questions and sort of seeking that feedback so that they can sort of have those skills and build confidence as they apply them throughout their career. It's hard though. It's a challenging feat a little bit.
Bren, what do you think since you are in the thick of this right now?
Yes, and I think Dr. Kraus made some great points about it can be challenging just because, especially as a student, you kind of get graduated responsibility as you go. And showing up as the third year med student on your first day of a rotation with a new team, nobody's going to be looking to you as much to be thinking critically. And a lot of your initial roles might just be you being told to do something and then you just execute it without much thought process. But there's still a lot of opportunity for ways to be creative and thinking through, okay, how did the team actually reach the differential? What type of thoughts should be in your head? And it's always really nice to have preceptors that can help you have those conversations and also give you like guiding questions. So you're not just the learner in the room who's hearing them talk to you like a lecture, but it's more engaging.
Yeah, so like, we all are adult learners, right? So we need to actually be doing stuff in order to actually learn stuff. Um,
Absolutely.
so I guess that goes to my next question, which is in all play. So you all are in the you and me space. So what makes a strong clerkship? How do we be successful? Like, we'll talk from like just an OB perspective. OB/GYN is notorious for being a very, shall we say, interesting clerkship for a lot of students for various reasons. So how do we make that clerkship experience successful and strong, especially for students that may not choose it as a specialty?
For me, I always think of like the two O's whenever we're doing like our planning and our meetings. And it's one, the objectives, like are the objectives clear? Are they attainable? Number two, organization. And usually when you lead with those two things that aren't necessarily emotionally bound, definitely are very like team driven, data driven, it can make a clerkship not just palatable for students, but enjoyable. I think a lot of times people think about it more from like a environment and like people perspective, but you don't really get to those points unless the fundamentals, so the foundation, the way in which it is built, and the experience is actually laid out for the students. If that's not to its core strong and well thought out, then I think that you can kind of really kiss goodbye the possibility of even a preceptor, one wanting to engage or knowing how to engage, or being able to engage effectively.
So when you
Yeah.
have, oh, sorry, go ahead.
Oh no, sorry, Laura. You want me to
No,
go?
no, no, please go ahead.
Yeah. No, I'm just so inspired by what Nora's saying. But I agree. It's I think some of it is, like she's mentioning the structure with the clear learning objectives that are then linked to essential competencies and assessments. In that setting, sort of like we mentioned, fostering this idea of graduated autonomy, experiential learning. And then I think engagement with faculty, fellows, and residents, are key GME players in their role in mentoring students, and providing them those opportunities for, like we mentioned, hands-on learning, and then really making sure they have a role in this sort of team-based practice that is medicine. This sort of multidisciplinary care, I think, is key.
Mhm, mhm. I agree. So when you have faculty on, whatever service line you're on, how do you provide them with those objectives, number one, as well as how do we communicate to our students what the objectives are? Because I think, the student going into labor and delivery for the first time or into an even an operating room for the first time is super intimidating. So how do we communicate that information?
I think there's more than one way in which objectives can be set. I think there are like assessment-based objectives, and then there's more of like those real-world practical application. I think one of the ways actually to have very successful preceptors is letting them to some degree determine what they believe are the objectives within that one-on-one encounter and giving them that autonomy to do so because the learning environment is just so flexible. Frameworks are important. I will say that we as a department have not necessarily done the best at giving frameworks for our preceptors. So it has muddied the waters in terms of them being able to ask students of meeting their expectations. And that's something that we're going to work on as we meet with each division in the next couple of weeks in talking about the new curriculum. But once that framework is set by the clerkship team, giving that power back to the preceptors and making sure that the students can receive that communication directly from their preceptor of that day or of that half day, I think is really important because, what's set between, for instance, abnormal uterine bleeding in the OR is very different than abnormal uterine bleeding in the clinic. Abnormal uterine bleeding maybe by a generalist compared to abnormal uterine bleeding by a MIGS provider. So I I think that one of the things that has been really stressful for preceptors at times is not knowing like what they should be giving students. But the definition of a preceptor is to teach, it's to instruct, and it's for them to leverage the learning environment to provide practical skills. They are the professional, they're the expert. So they can also decide to a degree what they think is the practical skill that needs to be worked on for that setting in that time frame.
Mhm, mhm. Let me play with you for a second. So, what if someone comes to you and says, "Oh my God, I'm so tired. I've got like a full panel of patients, and I have to go to a meeting, and I just don't have time to deal with extra people. Like, can't someone else do that?" How do you respond?
I think understanding that, as Nora was saying, part of being an effective clinical preceptor and educator is essentially dealing with this unpredictability in medicine and this sometimes this lack of time and these conflicting responsibilities. And so it's giving, the person that's come to you the confidence to say, even though you are, meeting all these barriers, there's still the time, even if it's something really, really, really small, to be able to engage with learners. Um, you know, in that sort of hectic clinical environment that you're working on and sort of giving them the confidence to do so. And then also, like Nora was saying, potentially reaching back into some of those, theoretical frameworks and, ways to sort of integrate those into the clinical space. And sort of, but also at the same time, I think letting them know that we understand that it can be difficult and we're all sort of at times struggling with those same, conflicting responsibilities, but at the same time, sort of attempting to still engage learners in an effective way, even if it's just in a couple of minutes.
Yeah, and I think that goes back to what someone else said earlier about even those really short moments that you may have with a student or that you may not want to have with student can make or break someone's career, or their ideas of what they want to do in medicine. Like I have a friend from med school who wanted to go into OBGYN since day one, and she had one or two bad days on labor and delivery and forever swore off being an OBGYN. And, that story is not uncommon, not just in OB, but in other specialties. And, I don't think that's okay. And so we need to do better as folks in positions to teach and to influence that, this is something that, we have to take seriously when it comes to being in the roles that we are. Um, Kayla, I'm curious to know from your perspective, as the clerkship coordinator, what do you think students are looking for when they enter a clerkship, and what do you think they need when they come to the clerkship?
I think from my experience, it's mainly having a system that the students can easily follow and that has clear steps of like what they need to do. I think having like great organization and communication as well. So if a student does end up in a situation that we are easily accessible in order to put out the little fires that come with the clerkship and with students. So I think clear communication and having a organized structure that the students can clearly look at and understand, okay, this is what is expected of me. This is what I need to do with this clerkship. I think really alleviates a lot of stressors in an already high stress clerkship when you are going into a new rotation on a new service. And so I think having as much organization and communication and structure as possible is what really students are looking for in a clerkship.
What do you think, Alex?
Yeah, I agree with everything, Kayla said. And I think the other thing is that this is sort of the first time when you think about when you applied to medical school and you were thinking about becoming a physician, what you were thinking about was this time when you would interact with patients and the skills that you would learn doing so. So I think students really desire to grow, in their clinical skills on rotation. They want to, further their professional development. They want to learn, like we talked about, critical thinking skills and really be effective communicators. Um, and do that in a space where they feel like, like I mentioned earlier, they can ask questions, they can encounter challenges, and then, sort of seek feedback for, continual self-improvement, on the skills that they're developing within the clinical sphere.
Nor.
I think students want to feel like they're a part of something. I think they want to feel like they have a place within our busy schedules, within a patient's very personal experience, within a group of random individuals who may or may not be intimidating, but also may or may not be accessible. And I think that what makes a strong clerkship is one in which the students to some degree have to work to, get into that space, but it's also very accessible and transparent for them how to be a part of that team, and that they know what those objectives are and they know how to get through them and how to meet those goals, and that there's someone there who's, giving them not just that feedback, but those touch points. I think that like students are really looking for that experience and feeling like that really that there's like a place for them within the team. Because at this point in their career, especially as third years, they're finally finding their professional identity, and all of these ideas of what a physician is like this is like that culminating point. And it can be really intimidating or it could be really exciting. So that excitement is the part that we really try to captivate, even if they don't want to do OB/GYN, that we're able to figure out what exactly it is that we can help to grow within the time that they have with us.
Yeah, I love that. So, in my perspective, talking to you all as someone who, did a clerkship way back in the day and sees what you do on a daily basis, sounds like that students really want clarity in what they're coming to do when they come to the hospital or to the office or the operating room. It sounds like that preceptors need clarity in what exactly am I going to be doing with these students that know nothing, or they may actually know more than you in some instances. And how do I make the clinical learning environment as successful for both me and my students? And I think that's so important when it comes to undergraduate medical education, particularly on the clerkship space. But is that really the case? So find out in part two of this podcast series, MedEd Matters, on what it means to be an effective preceptor when we talk to one of our own medical students about her perspective on the clerkship experience and what does that mean. And so stay tuned for our next episode.